Good afternoon, everybody. It's Fridays with Feldman, which is a Facebook Live and a video discussing different topics that we take care of at the Paley Institute and which I specialize in. So one of my big topics and one of the big conditions that I treat is arthrogryposis, which is a catch-all term for stiff jointed disease, and the most common form of that is AMC, amyoplasia congenita, and basically that is a condition, again, usually that we don't have a genetic form of, but there are many genetic forms of this condition as well. And because the procedures have changed, and I've even changed the way my outlook on this over the last 7 or 10 years, people have asked me for some of the data that we see in some of these new procedures that we're doing. So I'm going to take two procedures, and I'm going to talk about those procedures and show some of the data that we're actually presenting both at the Pediatric Orthopedic Society of North America in May, which was accepted for presentation, and also we'll be publishing in a peer-reviewed journal in the near future. But let's just talk about what it is that we are talking about. So we'll start with knee flexion to contractures. Kids are born with very, very severely bent knees. Forget the extended knees for a second. We're just going to speak about one condition, bent knees, that don't straighten with physical therapy, that require incredible bracing to try to get the children to walk or can't walk, and how we've gone from using external fixators, where I was an author of a paper published and looked at the results of that, towards increasing the range of motion, and let's look at the data. So first I'm going to show a video that Jeff Hafferman did. He's one of our elite physical therapists, and he actually put this video together of a young man who has no quadriceps actually, so can't straighten his knee, but he was actually bent knees, came from a different country, came actually from Poland, and treated him from the beginning until the end, and you're going to see at least that progression and how we got there. Now I'm going to show you some of the results. So this is a video made by Jeff Hafferman, one of our really terrific physical therapists here at Paley Institute. So here's the young boy back in February trying to stand and walk. And there he is on March 23rd, but the question is, how did he get there? So how did he go from this, before surgery, walking on his knees, could not stand, and that's all he could do. But obviously he's got good musculature, he's got good trunk control, but his knees are bent so significantly that he cannot stand on his own, even with bracing, and we'll show you how big the contractures are in a minute. And this video is not very long, but it's going to show you some of what we're talking about as we describe this. So many of you the children who are watching this who have AMC, have this. You can see that's I would say about a 50-degree contracture of his knee on that side, and perhaps an 80-degree contracture on the other side. And he doesn't have much flexion, even more than 90 actually. So this is now after the surgery. So this is now 5 weeks post-operatively, and now you see his knees going completely straight, but not just straight. They bend, and this is only 5 weeks after surgery. And you see we released his hips as well, so he no longer has a hip contracture. But this is functional. This is not just achieving that. So now he's showing you this young boy who's moving his knees at 5 weeks. He's pretty pain-free at this point. I mean, it takes really good therapy to get to this point after the surgery, but he had both of his knees done. And he goes from about 0 to over 90 degrees on both sides. So he's increased his arc of motion by about 45 degrees. And here he is 5 weeks, we're just letting him stand up. So I'm just letting him start walking somewhere between 4 and 6 weeks. We let him start putting weight on. Again, he has no quadriceps, so he has to use braces. Here he is 1 week after that last picture, 6 weeks post-op. That's Jeff in the background, holding him a little bit, and he's starting to ambulate for the first time in his life. He's actually walking upright. And now he's 10 weeks post-operative. No assistance from any of the physical therapists, and here he is using a single cane with his walking. And showing us how he doesn't really want the cane anymore. He's completely independent. And ringing the bell and finishing the physical therapy, which we call really a great moment when they ring the bell. And so there he was before, 90 to 110 degree range of motion, 55 to 100, 0 to 85, 0 to 90. And not only did we achieve the knee straight, we also achieved an increased arc of motion. We didn't lose our range of motion. So now we're discussing what this new procedure is with no external fixator. Now we can discuss what it is that we did. So we did the first 75 patients, about 120 knees, with at least follow-up for 6 months. So I started doing this in October of 2015 was my first case, and then we started picking up from there. As we described this procedure, really it came about from a young man from Italy I treated when I was at NYU, and then really evolved as I came to Paley Institute, because it's really why I came down here, to really specialize in certain conditions. So this is the data. For people who like data, I'm going to show you the data. So these are the numbers. So you can see preoperatively, patients have about a 50-degree or 60-degree flexion contracture of their knee, and they range to about 110. So somewhere about a 40 to 45 degree arc of motion, and that arc goes from 60 degrees to 100. So they're bent, very bent knees and can't straighten. And these kids mostly were not braceable to even walk. And right after post-op, before they left for home, they were somewhere between 0 and 15 degrees, and they went anywhere from 50 to 100 degree range of motion. And even in follow-up, they did not lose much of that flex. They did not recontract. They recontract a little bit, maybe 15 degrees in this blue box, but not any more than that, and they never lost their motion of flexion. So this takes a lot of physical therapy afterwards, but it is certainly achievable. This is the arc of motion. So we talk about an arc of motion, and let's talk about what that means. If your knee goes from 45 to 90, then you have a 45 degree arc of motion, right? 90 minus 45. If your knee goes from 0 to 90, then you have 90 minus 0, you have a 90 degree arc of motion. So most patients started with somewhere of an arc of motion between 30 and 60 degrees, and they ended up with an arc of motion somewhere between 60 degrees and 90 degrees. So they really increase their arc of motion, and this actually increased with time, because basically they get more flexion over time, and that's what we're working on now, is not even to settle for 90, we want to get 100, 110, even 115 degrees. And these are just the values of the standard deviation showing the p-values, and this p-value means that the chance of this happening randomly is 10, 100,000, 1 in 10,000 chance that this could happen just randomly, these numbers acting like that. And similarly, with this, we gave p-values for all of it. So, let me see if I can go. So basically, this just talks about how many children are ambulating. About 84% are ambulating afterwards. Only about 41% ambulated beforehand. So most of these children have gained ambulation. Now, why wouldn't you gain ambulation? Mainly because you're missing all the musculature, and then or you don't have the trunk control to know how to do it, or you're much older, or it's revision. So we did look at some of the reasons why kids did better or worse. Certainly not having procedures before was much better. Certainly younger, somewhere around the age we think of 2 to 3 is probably the best age. But when the paper comes out, we will certainly send it out and put it on our website so everybody can have all the specific data. And I'll put my talk that I'm giving at the Pediatric Orthopedic Society, I'll put that also online so people have. But you can look at the age of surgery. The average age of surgery is about 6 years. Our average mean of follow-up is about 16 months. So we're not just talking about 6 months. We're talking about really a pretty significant follow-up time. Maximum range is 34 months because I couldn't find the first couple of patients I operated on. And basically, these are just the numbers that we're looking at. Complications. Let's talk about complications. Everybody wants to know about that. 4 patients had fractures. We had 2 recurrences, 1 revision, 1 wound complication. Limb length discrepancy we expect because we do shorten the limb. 1 didn't heal well enough, and 1 developed a little granuloma, which is a little over the scar. So a total of 7 complications in terms of this follow-up. Okay, I'll just show this for 1 second, because that's the data for the lower extremity. So I will submit this. It will be written up. It takes time to publish new procedures, but new procedures are viable sometimes, and certainly I was doing the old procedure, so I can certainly compare the two, and perhaps in the article we can do that as well. This is another thing which I started doing this operation was done for both polio, for brachial plexus injuries, but never really used for arthrogryposis to give people biceps function. This young girl, I don't have a recent one, this is just after surgery really, her starting to use her arm to get for biceps function. So she starts being able to feed herself, and she couldn't raise her arm before. And I'm not going to spend a lot of time on this, but certainly this is a good operation for gaining biceps function. Again, a new operation used for arthrogryposis or AMC, and not really used before very often. So I've done 12 elbows in 11 patients. All patients achieved that muscle worked because we get an MRI before to make sure it exists. Afterwards, complications, well, one had a radial nerve palsy, which is in the figure, that got better by itself. And one patient, we had to take it off the radius and put it onto the ulna, and now the ulnar nerve is also a little bit, somehow has to be what's called decompressed. But, sorry about that. But those basically are those 12 patients. I haven't done 100 patients of those, that's for sure. The knees, we've had much more experience with those. But that's a way of gaining bicep function, and we've done it. We've at least reviewed our first dozen after 6 months. So I know there's been some questions before which I'm going to answer, and I think Mckayla is going to read me those questions, and then I'll answer. I'll take any more questions if you have during the Facebook Live. I could certainly answer those. So Mckayla, questions?
Talk about AMC and the combination of stiff joints and weak muscles, the approach to orthopedic surgery if the muscles are not working.
Right, so the question is, what do you do if the muscles aren't working? Well, in AMC, many of the muscles aren't working. The question is to find which ones are working. So in many of these patients with the knee flexion contractures, but quadriceps don't have to be working. You may need a long brace. Sometimes I can transfer a hamstring to the quadricep to see if that makes them not have to use the long brace to walk. But even if they use the long brace to walk, they can unlock it and sit normally. The key is to have knees that bend, because you need knees that bend to sit in a chair, to sit in the school, to sit at work, to sit in an airplane or a bus or a truck or anywhere you want to sit. And so muscles completely being absent, or obviously some kids have that, where there's just nothing to work with. But many times there are some muscles functioning and some absent. And I think that is a really good question, because the combination of contracture with weak musculature, I can't treat weak musculature except with physical therapy or perhaps transferring a muscle like you saw what I did for the biceps. But you can make the kids not contracted, which gives them much more function. We don't have a way yet of making muscles. Stay tuned for 2025. But right now, at least, we don't have a way of making muscles when they don't exist. So I think balancing is what you really need to be able to achieve.
How young can treatment begin?
So the question was from Mckayla is, how young can treatment begin? So that depends what you mean by treatment. So I don't love doing surgery early. So now I'm quite fortunate. I have one of the world's expert in clubfoot and vertical talus working with me, Dr. Dobbs from St. Louis, who moved down to the Paley Institute. So I think the club feet and the vertical talus start very young, and I think I've started to give those very young patients over to Dr. Dobbs. I was just actually privileged for the first time in my career to have a child born here at St. Mary's Hospital, because with arthrogryposis, I met the parents on Zoom or telehealth before a few times, and I actually was in the birth of the child, and really was able, and even that's a conversation we could have one time, maybe in a different one, how should we do dealing with fetal tissue in some way, but was able to really tell them exactly what the baby had, show the nurses how to handle the baby, not to be too fearful, and the baby's fine, going home today, and little William is adorable. But I think that it starts really young with physical therapy. I don't usually do knee and hip surgery before 18 months. The caveat to that are the extension ones. The knees that are fully straight, many of those kids we'd like to operate on much younger. But certainly I like to do surgery somewhere between the age of around 2 for the knees and the hips. 18 months if the hips are dislocated. I don't love doing surgery much younger than that. Dr. Dobbs now is doing the feet for me, the vertical talus and the club feet, and he certainly addresses minimal procedures at a much younger age, even after birth. So usually we have our physical therapists meet the child very young. The sooner the better. They begin early intervention, splinting. Fran Guardo, her group, Jeff Haffman, Dale, all of them. I'm not missing any names, and then we have Nelda and Mary, who are our occupational therapists. They're Nelda Posada and Mary Beck. Fran Guardo is our chief physical therapist. And all these people, between Dale Federico and Jeff Hefferman, and again, I'm not leaving out any names for any reasons, but all of them start very young with the bracing and the working on the therapeutic standpoint. Then I meet them, and then we work out a lifelong plan of, me getting involved with surgeries a little bit later in life.
Lung capacity being reduced because of severe scoliosis and operating so they don't end up in a wheelchair.
Yeah. So those are two questions just asked by Mckayla from the Facebook Live. One question was, how do you prevent patients to developing lung insufficiency from scoliosis? So certainly that's a different conversation. The young arthrogrypotic child who has scoliosis, and how do you do that? I just saw a child yesterday with that. So Sheldon Hall syndrome, and which is a syndrome like arthrogryposis or a form of it, and a very severe young 3-year-old with severe scoliosis. And that's what many times you have to address. You may have to use traction beforehand. I have a young boy coming in this week who's going to be getting traction, and then going from the traction to, for a month in the hospital, literally, a month in the hospital with every child life specialist. I put a young man in traction for a month. He was 20 with arthrogryposis. And he's a writer, and the child life specialist got him all these authors to call him, and he zoomed with them and learned how to write while he was here. But basically, put him in traction, and then once you have enough lung capacity and you've established that you treat them early, then you can fix the spine either with growing rods in very little kids, which are those magic rods you've heard about, which grow automatically, or growing rods that you may have to lengthen if the kids are very young. But the key is to maintain the chest capacity, like you said. Sometimes that's by expandable ribs, sometimes it's by using magic, sometimes it's by doing scoliosis surgery, sometimes it's a tether, which I'm doing from a little young girl, 12-year-old, because I want to keep her motion. So there's so many options, and I think scoliosis should be a different conversation. In terms of the wheelchair, I will say that I can get most kids out of the wheelchair, that's for sure. We showed that 84%, it's pretty good. And I think that we get them to walking at home, walking at school. Are they going to walk at Disney World? I don't know, maybe not. But they're going to walk far distances independently, even if they don't have quadriceps. You don't need quadriceps to walk. If you have quadriceps, then you're going to run and jump, and I can show pictures of those. They're amazing. But those are we call those 1As, and we have a classification for it. But certainly, the wheelchair is not something that I want the kids with AMC to be living with when they're young.
How do you treat leg length difference in AMC? Is it recommended to lengthen, and what impact does that have on the muscle contracture that was previously corrected?
So that's a great question. So the question was, what happens with limb length inequality? So it's more uncommon limb length inequalities in patients who've had both their limbs performed, right? Because we shorten both limbs almost equally and try to make them pretty close. There's no question of limb length inequality. It could be an issue. The best way to treat a limb length inequality in a child with AMC or an adult is to slow down the growth of the long leg. If you can, it can be lengthened, but lengthening can stiffen muscles, so you've got to be very careful. Certainly shoe lifts are used. So you need to know the amount. I think all options are out there for us, whether it's internal lengthening when they're older, slowing down the other leg, and just making sure you're somewhat equal between the two, or a shoe lift if the patient chooses to just do that because it's too risky to lengthen. So I think that it just depends on the patient, how stiff they are, and then you take that and you treat the limb length inequality. Certainly one component to making kids walk is to shorten the limb, but most of the time it's both sides and it becomes equal on both sides. But sometimes one hip is dislocated, one hip is not. So this is not an uncommon problem in kids with AMC.
Can you talk about hips? What is the surgical method you used for grade 4 hip dislocated with AMC?
Well, so the question was about hips and AMC. So this is going to be a point of controversy, I think. So I don't think the kids should have the operation to bring their hips under their body when they're young. In fact, I know they shouldn't, because you destroy the angles of the hip. So there's many things you can do. So first of all, the question is, complete like grade 4 dislocations. That was a question of what grade 4 means. It's a high dislocation. If it's moving well, I'm not sure why you're treating that. I'm not sure I'd put that back in place. That is not the same as a Larson syndrome, but for an AMCer who has a very high dislocation, you have to figure out, is it moving well, is it not moving well? Are you trying to achieve motion or relocation? You can walk with dislocated hips. But most hips you do put back in, most hips go back in the joint. And you try to keep them moving. So I don't cast the kids with hip dislocations, you put them back in, you use a tether to hold it in place, and you try to keep it moving. Doesn't mean it's not complicated, it's still complicated. They come out the front, they can come out again. So these are issues in AMC, but again, keeping the motion is more important than relocating. What I really want to talk about in the hips is the hips that are seated in the joints, but the kids hold their legs in that frog position, what's called abducted flex, right? They're all the way up and out. I had a child this week who I did one side on, probably the worst I've seen of that ever. Abduction, flexion, and you don't have to break the bone to turn it in first. You can treat the hip and the knee simultaneously. All those kids you saw had hip and knee treated simultaneously. Only about 25% needed the hip, because sometimes the hip comes around when you just do the knee. But 25% had the hip operation, but not to break it and bring it in. You leave the angle alone, and you can shorten the musculature without shortening that part of the bone, and that allows the hip to come in. So there's many tricks to the hips in AMC.
Any new data on knee replacements to increase range of motion?
So the question was, are there any new data on knee replacements to increase the range of motion in AMC? No. The reason I didn't show that, I've done some knee replacements in AMCers, but I don't have enough data to prove that it does. I know, it certainly increases the range of motion. I've done enough of them, a few of them now, they increase the range of motion. The question is, can you gain strength enough to maintain strength with it? Certainly, certainly for the patient who has extended knees, can't sit and wants an amputation because they just don't like living with their knees straight, or a knee replacement is much better. When I have the data, when I've done many more of them, and I work with Dr. Minus, who came down here from Harvard in Massachusetts, and he's the person who does my knee replacements for me, and I operate on the soft tissues while he's doing that at the same time. So we do them together, and it's been successful, but without data, like, oh man, this is a data-driven point, so I don't have enough data on that. I'm starting to do that now, and I think it's going to be successful in a way, but it's risky, right? There's not enough muscle, you could get an infection. This is not without risk. It has to be done very carefully and very thoughtfully. So same with hip replacement. So I think we need to have more data first before we really recommend that, and it's on a patient-by-patient basis. Right now, certainly if a patient comes into me and says, they're 14 years old, straight knee, can't bend it, and wants an amputation, then I say, please let's try a knee replacement first. If I can't do anything else, I don't want to amputate the leg. So I think that is the option, and we are doing that now for them. So when we have more data, we'll certainly give it.
How do treatments change as children with AMC go through puberty and into adulthood?
So the question was, how does treatment change as kids go into adulthood or as they reach puberty? And that, again, that gives other options, right? I think that we try to get most of the things done between the ages, literally, of 2 and 4 or 5. That's really, 5 is upper extremity because they have to cooperate. So, before they start first grade, I want most done. But all the operations we do, let's say when they reach puberty, are the ones that we're talking about. Maybe knee replacements, maybe hip replacements, maybe equalizing the limb length if they don't want to wear lifts. So I think that's really when we talk about those operations, scoliosis operations for the spine. But be very careful with scoliosis because it may make the child not able to flex their hips enough. So you've got to be really careful. So I had a young boy who came here from Utah who basically couldn't bend his hips. Well, I couldn't do his spine until I got his hips to bend. Once I got his hips to bend, then I did his spine. Now he can sit, stand, ride a little bicycle. He does different things. And so he's still very young. When he reaches puberty, right now he has magic rods. That's when you switch those magic rods perhaps to fusion rods, or you think of something else like tethering and do some other things as they approach puberty. So that's girls when they first get their menses, boys when they first start reaching puberty.
What would you do about a bended and short ulna on a 3-year-old? Here they don't want to do anything.
So the question is upper extremity thing. So I'm very aggressive on upper extremity. So the bent ulna causes the radial head to dislocate. That I can show in MHE, in multiple hereditary exostosis. So you try to keep the elbows reduced, and that's a different topic in terms of what do you do for the upper extremity in arthrogryposis, and that's really, I think, really becoming fascinating. My partner, Dr. Hoosier now, who does the hands on these kids, getting the thumb out of the palm, certainly never cast. That's first of all, never cast the upper extremity if you don't have to. So you get the elbow moving, first operation. Or the first operation to get them externally rotated so they can keep their hands in front of them. Then get the elbow moving, flexion extension. Keep the radial head reduced if it's not already dislocated. That's a question to answer the bent ulna. Straighten it. If it's reducing, if it's dislocating the radial head. Once the elbow's moving and the kids have some grasp and some function, then you start looking at transfers if that's possible, which is not possible for every child. But if you can get the passive motion, at least the patient or the child or adult can lean against the table to eat if they can grasp. Again, we can't make muscles if they don't exist, but we can take one from another and try to at least create some function if there's some underlying function to start.
My baby is 10 months. We haven't planned yet a treatment for the hip. We went through 2 appointments with different pediatric orthopedists, and here in Brazil they consider that as a risk treating a bilateral dislocated hip with AMC because of the possibility of increased stiffness and worsening mobility. What do you say about that?
So the question is from Brazil, and the question is whether or not a dislocated hip in a 10-month-old does that increase your risk of stiffness if you put the hips back in the joint? And again, I think I was mentioning that before. It really depends on the child and what kinds of arthrogryposis they have. I don't blame them for not wanting to put it in, but I think that there's been a lot of good research on putting the hips back in is helpful if we can. And certainly if I saw a 10-month-old who had good motion, but I wouldn't cast them. So my answer is that I don't love doing the dislocated hips until they're about 18 months of age. There are people doing them younger who they do medial reductions, but I worry about anterior dislocations. I worry about stiffness and redislocations. I've seen a lot of stiff hips, and I agree with your doctors in Brazil. But there are methods to do it, to put it back in and keep it moving. And one of them is using tethers as opposed to cast, so you maintain the motion as you do it. Motion is more important than the x-ray. That's what I would tell you. So if the child's moving their hips very well, then you can do that. Now I'll say that in Larsen syndrome, I've regretted not putting hips back in because they need it for stability. Arthrogryposis, I think it depends on the child, and I have to see that specific case, whether or not you'd actually undergo bilateral hip reductions or not. One side for sure, you would. Yes.
Muscle transfers in legs. I have a child without quads.
Yeah, so I'm working on that. That's a good question. The question was, this is by far the most questions I've ever had on a Friday with Feldman, so obviously this is a good topic. So the question is, this person has a child with AMC, does not have quadriceps. Is there a muscle you can utilize? Well, if there's a good biceps femoris, which is a hamstring muscle, and there's some other hamstrings, which I'm not stealing all the hamstrings, I would try to do that. I don't know the actual results of that yet, because I've only done that a few times, and we'll see if it can really replace the quads. It's hard, but they can walk without quadriceps. As long as you keep the motion, you can use a long brace, and then they can walk. And I have lots of what I call 1Bs. Lots of kids without quadriceps running around, little Jack playing golf, doing different things and running. Even that boy you just saw who came from Poland, he's a 1B. He has no quadriceps. He's running around. Yes, he's locking his braces when he runs around, but he's running around. Now, if you have quadriceps, somebody can take a muscle, the biceps, and then you can only wear a short brace or no brace. That obviously would be quite nice. And we'll see. We'll know certainly more as I transfer more muscles, but the biceps femoris. Mothers always ask me, can I give my muscle? The answer is no. We can't take a muscle from a parent or someone else, or from a different location on the body as of yet.
Any helpful planning advice for families who have recently received an AMC diagnosis heading into the 3rd trimester?
Yes, I would love, the question is, you were diagnosed in utero, or during your 3rd trimester, or before with AMC, and you're going to have a baby with AMC. We are happy to do, my partner and myself, Dr. Hoosier, telehealth, Zoom calls with you, and really, have you understand. You'll get us the ultrasounds, you'll get us whatever you have, and we can have a conversation about what you need to be aware of. You should have a cesarean section. They should not straighten the baby out when they're born so they don't break something. All these things are really crucial knowledge to have. And then what do you do afterwards, and how are you going to do it afterwards? So certainly we're happy to talk to you from wherever you are in the world and try to map that out. We recently spoke to a child from Vietnam. I've met with many mothers from different countries and this country while they are expecting, and parents. I think the patient I just told you about that I was there for the delivery, they were so prepared, the parents, and they're so wonderfully in love with their little son and ready for this adventure and this journey. And they knew the problems. And sometimes the ultrasound looks worse for this child. They said the hands were bad, and I didn't think they were, and actually the hands are fine. So I think that you don't get carried away with expectation. But you approach it, understanding what you're going to do when the baby's born. So, the mother who's having the baby is not overwhelmed. They don't cast the baby in the hospital. You don't start. You just bond with your baby, and then we can certainly help before that.
What can be done for a 20-month-old with partially fused knees?
Yeah, so I think I need to see those x-rays. I mean, so the question was, what do you do with a partially fused knee? I would need to, with a 20-month-old, I need to know what that means and look at that. Is that is there something else going on? Is there more of a congenital anomaly versus arthrogryposis? So certainly that would be a great case. Again, if you're far away from Florida for telehealth, which has become really very famous, very prevalent during COVID. So yeah, I would love to see the x-rays and see the ultrasounds or see what you have, and also clinical pictures, and meet with you and see what that looks like and see if there's an answer. Because partially fused is sort of like being partially pregnant. Doesn't have much meaning to me. I need to know, what that means. I mean, you can't, either it is fused or it's not fused. So we have to see exactly what that means.
My daughter is 4 months old. Her legs lay up near her arms. We are waiting to see you, but is there anything you would recommend?
So the question was, this baby's 4 months old. They're actually flexed. I mean that their legs are up by their head, and that's where you need a good physical therapist, an occupational therapist. They need to start bringing it down slowly, start unfolding the child, start mobilizing the child, A-stim. And so, one time I think what we'll do is we'll have Fran Guardo, maybe Dale and Jeff come down and discuss that's a great Fridays with Feldman, is the infant with AMC, right? The infant with arthrogryposis. What do you do during that 0 to 6 month point? And that may be, but basically that's a lot of physical therapy and splinting, and the occupational therapists. We have our occupational make the splints because you outgrown them too fast, serial splinting. So I think it really is quite successful actually if you do that. All right, so I'm going to end Fridays with Feldman today, wishing everybody a better 2021 than they had in 2020. No matter how good your 2020 was, hopefully your 2021 will be better than this for the world and for us together. So wishing all of you a Merry Christmas, a Happy Hanukkah, which is the last day today, Kwanzaa, Happy New Year. For all of you out there who celebrate in the next month, and wishing you and your family health, which is obviously all we want, prosperity,